Good afternoon, and welcome back to HealthLeaders, the Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Luke Gale. I am the Revenue Cycle Editor for HealthLeaders and will serve as your moderator for this session. Today's program is titled The Winning Edge for Patient Payment Success, sponsored by Waystar. Thank you to our sponsor and to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Our program will be approximately 60 minutes in length. Note that an on-demand version of the program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists. Ryan Klein, Senior Director of Patient Access and Financial Experience at UW Health. Mike Lorenz, Director Revenue Cycle, INTEGRIS Health. Eric Sulivant, Solution Strategist from Waystar. And Andy Talford, Senior Director of Patient Financial Services at Moffitt Cancer Center. Thank you all for joining us, and with that, let's get into our discussion. First, please tell us a little bit about yourselves and organizations. Andy, would you like to start?
Yeah, sure, I'd be happy to. Hey, everybody, I'm Andy Talford. I'm the Senior Director of PFS for the H. Moffitt Cancer Center in Tampa, Florida. We are a NCI-designated cancer center, opened around 1986 in conjunction with the University of South Florida. I'm glad to be here. A lot of cancer patients have a pretty precarious financial journey. So I'm really looking forward to this discussion today about how we can limit that. Thanks.
And Mike?
Yes, I am with INTEGRIS Health in Oklahoma City. We are the largest Oklahoma-owned health system and one of the state's largest private employers with a little over 10,000 employees. We are 22 facilities between joint ventures and wholly owned, and just expanded with 20 new urgent care centers in this last 18 months.
Thanks, Mike. Ryan.
Hi, everyone. Ryan Klein, Senior Director of Patient Access and Financial Experience at UW Health. So I support registration, prior authorization, financial counseling, which is estimates and financial assistance, as well as our customer service and self-pay. I work with UW Health based out of Madison, Wisconsin. 6 main hospitals, about 1,500 beds, and just under $6 billion in revenue.
Thanks, Ryan. And our final panelist, Eric.
Yeah, hey everyone, Eric Sulivant, Solution Strategist at Waystar. Waystar is a healthcare revenue cycle and payments technology company that's really focused on providing everything from pre to post service solutions with things like eligibility, estimation, prior authorization, claims clearinghouse, as well as patient payment. So I know that's the focus of today's discussion. So looking forward to it.
Thanks, Eric. And we'll get to our first question. What are the biggest challenges revenue cycle leaders encounter when collecting patient payments? And Mike, if we could start with you.
Yeah, I think probably the largest challenge right now is just patient education. A lot of the things that roll up into that, whether it be estimates or understanding of collections or understanding of what the payment involves, but just in general, being able to provide the education to the patient so they understand what they're paying and how that affects the outcome.
Thanks, Mike. Andy, do you have anything to add to that?
I would agree wholeheartedly. I think when we talk about oncology care, which is what I do, patients are seen over a long period of time and with a pretty expensive care. So I think getting a good system to give good estimates that patients trust, sometimes that trust factor has to be built into that, where we come up with a really good out-of-pocket information so that patient education is a big part of that. Yeah, agree.
Thanks, Andy. And Ryan, do you have anything to add?
Yeah, I think there's a longstanding tradition or culture of patients receiving medical bills after services are provided. And we all know that's changing dramatically to what Andy was saying. I think we have to ensure that the patients are educated. Those patient estimates are just that, estimates. Each payer and plan have their own benefits. We inconsistently get provided benefit information on RTE, and those payers apply all those benefits fairly differently. So ensuring those patients understand that those pre-service estimates are just that, estimates. But I think the other thing is that we're continuing to see an increase in those high deductible health plans, right? And those higher out-of-pocket costs than they've ever had before. And that continues to shift, while at the same time, health systems themselves are seeing additional efforts in legislation and across public perception as it comes to limiting our ability to collect those patient liabilities. That also has to be taken into account.
Thanks, Ryan. And Eric, what are you seeing across the industry at Waystar?
Yeah, I mean, to echo what everybody said around education, I think that's a huge part of this. I mean, I think for some providers, it was mentioned about high deductible health plans, right? So I think for some providers, patient payments or patients might be the second largest payer for some providers, right? Not all. So that shift from a decade ago or even longer, that's been drastic from a patient collection standpoint. Again, education around confusion around what a patient owes, if we can get ahead of that, whether it be having an accurate estimate prior to service, and then of course if a patient gets a bill, being able to explain what the bill is, and whether it be having the deductible amounts communicated to them around the education. Some patients may not even know what an EOB is or what deductibles are. So I think, again, the theme of education, I think, is what our clients are saying a lot and what we're seeing.
Thanks, all great answers. Moving on to the next question. What role does technology play in the patient payment experience? And Andy, would you like to start off?
Yeah, I mean, I think it's huge here lately. We used to sort of do this on the back of a napkin or something. I think now, like Ryan was talking about earlier, there's different payers have different out-of-pocket amounts. Some of them are based on your payer contracts, right? So you've got to have a system now that's able to sort of pull this, all into and give you a relatively realistic patient out-of-pocket number that kind of is specific to patients. And I think that's one of the things. And I think even the delivery systems, in our world, to say, how are patients even getting that information? Like, do they get it from someone on the phone? Can it be emailed to them? Can it be texted to them? Are there other ways to include them into this process? One of the things that we've tried to do at Moffitt really is move a lot of this patient discussion of out-of-pocket information, like I think Ryan also mentioned earlier, was it used to be you get a bill in the back end, right? And then, surprise, here's how much you owe. I think the move now is to try to move this as forward into the process as we can, so patients start their journey with a pretty good understanding of here's what I owe. Some places are even taking it the next step and saying, here's what you owe, how would you like to pay that? And here are even some ways we can talk about how to do that going forward. All of that is technology driven. I mean, it's just all, you've got to have something there that does that for you in this world.
Great, thanks, Andy. And Ryan, how are you using technology at UW Health?
I mean, I guess I would echo almost everything that Andy said, right? As a health system, UW Health has been really focused on the patient financial experience, and we've leveraged the technologies of our vendors and our partners in this space. They've allowed us to auto-create a number of estimates based on the provider order and the visit type, auto-create these estimates and then send them to the patient in their preferred method of communication, right? So that's going to be via the portal, email, text, call, whatever it's going to be. That same technology has allowed us to communicate to the patient how they choose both prior to and after service, right? So if that comes from our estimates that we're sending on the front end, or to the bills, to the billing notifications, to the, hey, you have a new balance, right? That statement hasn't even been created yet, but you have an updated balance. That technology has allowed us to actually reduce the number of statements we're creating, reduce the cost of sending out those statements, those additional calls, right? And then when we're checking in patients via kiosk, a desk, or on their phone, our team members or the patients are being prompted to either pay in full or set up pre-service payment plans or apply for financial assistance, right? That's all based on propensity to pay data that we have and the patient's payment history score that we have within our EHR, right? So we're truly trying to leverage it as many places as possible, customize it to the patient, and then be as transparent as possible, right? Let them know as far upstream as we can, and then help them understand the different resources that we have available to help them out.
Thanks, Ryan. Great answer. Eric, what do you have to add?
Yeah, maybe I'm a little biased because I work for a healthcare technology company, right? But obviously it plays a huge role. I always like to think about my experience as a patient, because we're all patients, right? I think from a professional standpoint, we usually break it down into 3 different areas, right? Whether it be before the visit, like others were mentioning already about, trying to get that estimate up front, having accurate eligibility checks, all that, that's important. So technology drives that. And then point of service, it should make, just for the patient, easier to pay, whether it be a simple copay or a co-insurance or a prepayment of some sort. Just like checking out maybe at a retail store. So things like contactless payments, being able to store cards on file with things like payment agreements or traditional card on file. And then, payment plans, being able to set those up too. And then also empowering the RCM team members to be able to communicate effectively with the patient, with the theme of education. If a patient has a question about, what their deductible is or what they're still remaining on their deductible, those are all important things for the staff to be able to communicate with. And then also after the visit. So after the visit, whether it be communication with the patient, meeting the patient where they're at, whether it be text, email, or a traditional paper option, all that's driven by technology. So, and I think another way to think about it would be technology shouldn't feel like tech, right? It should be more convenient. So making it convenient for the patient to be able to pay on their own terms, on their own times, and having affordable options too.
Thanks, Eric.
If I could jump in here.
Go ahead, Ryan.
Is it okay if I jump in here?
Absolutely.
Yeah, I think that payment plans can't be understated, the importance of automating those, right? As we were talking about it before, those high deductible health plans continue to grow. Patients don't just have that cash available right now. And without getting them onto payment plans and storing those cards, right, as was said before, and having those automated payments on a monthly basis, it makes a huge difference and reduces the amount of effort that our teams are having to do when it comes to outreach. So I just really wanted to emphasize that that's been a really great positive experience for us at UW Health. And we've seen, we haven't seen many people defaulting on those payment plans once they're set up.
Mike, are you doing anything similar at INTEGRIS?
Yeah.
Let's let Mike give an answer, and then we'll get back to you, Andy. I do want to hear from everyone here.
It's funny because we actually just recently had an experience with rolling out some new technology. We had been using some a vendor for payment plans and stuff, it was self-enrolling and was pretty nice. But we moved to MyChart, the full MyChart billing in Epic. And one thing it did is it pulled in every old balance that you may have into MyChart, even if it was from 4 or 5 years ago. And so that little notification popped up. before we had even really made any impact or even really done any marketing of, hey, this is now available, that first month we had over $1 million in payments, all on stuff that was over 2 years old. Just the simple fact of putting it in front of somebody and making it easy to pay. I think technology it's a central role at this point in how the patient payment experience is going to work, and the expectation is for it to be simple and easy. And we've got to continue to make sure that we stay current with the technology as it evolves. And just because it's great today, it may not be the best option next year. There may be better options.
Thank you, Mike. Andy, you wanted to add something?
Yeah, not trying to grandstand. Sorry. When Ryan was talking and everybody was sort of talking, my mind went to one other thing, and that is something that was said, like, we kind of move up front what we can do for patients. And I think payment plans, estimates are great. What I've seen a lot of success with at Moffitt is we actually move up front, even screening for financial assistance, looking for Medicaid if the patient's self-pay. So we do a lot of this front-end screening as well. We also do free drug screening at Moffitt. If you're in oncology, you understand drugs are a lot of the cost. So a lot of that gets moved forward, and that is all technology-based to look through and find all that information as well. So I just wanted to throw that in.
No, thank you very much, Andy. We appreciate that. We'll move on to the next question here. Unless anyone else have anything to add on the role of technology and patient payment experience. Great. Moving on, you've all touched on this a little bit, but how important are accurate pricing estimates to successful collection of patient payments? And again, you've all touched on this, but how are you using this sort of new enthusiasm for pricing estimates as an opportunity for education, which you've all touched on earlier, or to talk about payment plans, like Ryan was talking about just a second ago? And Ryan, why don't you start?
So I think you said enthusiasm about estimates. I think that's from the provider perspective. I don't think that enthusiasm is necessarily shared from the patient, although there's a lot of talk, right, at the legislative level about pricing transparency and how much this benefits the patient. And I do think there's value to that, right? What I will say is that there's a direct correlation between pricing estimates and then pre-service collection, right? But to your point, that can only be true if the patient trusts the estimate and estimates reflect the actual patient liability. So I think that we really emphasize the word estimate, right? There are a few people, when we really emphasize the word estimate, that expect 100% accuracy for their out-of-pocket costs, especially when you take into account labs, imaging, things like that. So with all of our estimates, we make it very clear what we are estimating for. And there's additional language within the estimate itself that always says if other services are provided, such as labs, such as imaging, that there will be, or there may be additional costs. We automate the creation of a majority of our estimates by payer. And we set a minimum of a 80% accuracy target before we automate them, right? And that's by payer. We measure estimate accuracy as most do in the Epic community. We're an Epic shop, which is either between $50, or you have to be within $50 or 5% of the actual balance, the estimate versus the actual patient out of pocket. And then Epic's estimate module has been definitely our most effective tool. We look at it, though, pretty uniquely. We don't use the standard out-of-the-box reporting that we get from our vendor. We do a lot of different reporting in different ways, looking at it at the actual, not only at the payer level, but at the plan level, by service lines, all kinds of different ways to try to trend out and identify those additional opportunities. So we send out about 1 million estimates a year, which is about 30% of our outpatient services. So it doesn't seem like a lot, but it's a lot to us, right? It just depends, I think, on the size of your system. So I think there's a lot of opportunity in this space, but it gets back to education and consistently providing patients with that education. Here's your out-of-pocket costs. Here are your choices for payment. But they have to be accurate. To get back to your point, they just have to be accurate. Otherwise, it's just you lost a lot of trust.
Great, thanks, Ryan. And how do you feel about that, Andy?
Agree 100%. I think we're not quite as far down that road as how many estimates we kind of run through the system in a given year. Right now, we automate all estimates for our self-pay population. We're pretty good to, because oncology, most of our patients hit their out-of-pocket max. So we know what that is. So that's kind of where we go with estimates. If you're in treatment with us for an extended period of time, you're probably going to hit it. However, we had a significant problem with bad debt in the self-pay population. And so our domestic self-pay, we estimate 100% of those, and we require a deposit based on the estimate. So patients pay for that up front. The other thing that it did for us is we actually compete in the international market a little bit. And as an NCI designated cancer center, we want to be able to have a good estimate to say, from someone coming in outside of the United States, here's what we can offer as it relates to all the other designated cancer centers that are out there, and compete on price. So it's really important for us to have estimates right in that area. And that's kind of one of the places we focused originally. We're working on commercial payers and the rest of that, but we're not there yet.
Great, thanks, Andy. Mike, do you have anything to add?
Yeah, I think everybody's spot on with the fact of accuracy is, it's not even optional. And I think the other thing to consider is what we may feel an estimate and we're accurate. No matter how well you educate the estimate, you've still got a kind of a standard deviation you've got to stay within. Nobody wants a surprise, and in the current, price transparency, what the media is putting out, what the public perception is, estimate should be like when you take your car to get worked on. They're pretty well, within a pretty close range of what that final bill is. And, I think it's back to that education thing again, that, there may be things arise during surgery that, unlike your car, they can't call you and ask, hey, you want to go ahead and do this because it's going to be an extra $5,000. But there has become an increased expectation of more accuracy, even than what it was 3 to 5 years ago.
Great, thanks, Mike. And Eric, sounds like your 3 co-panelists are all in agreement here. Is pretty much everyone across the industry in agreement here?
Yeah, no, I agree, obviously. But again, going back to what I said earlier, just taking it from a patient's perspective. Ryan obviously talked a lot about the trust aspect, and Andy talked about the surprise bill aspect and all that too, right? But I think, we've seen that scenario countless number of times. Obviously, technology can play a huge role, whether it be the communications to the patient prior to service. And then the others, I guess, angle to look at. I've been in a scenario where my son's provider, we had a visit. We prepaid for his visit, and then also some services he had. Was not there's no disclaimer at all about, hey, health services might be added without your knowledge or anything like that. So we show up, a couple weeks later for a follow-up in a small lobby, and the person at the front desk was telling we owed $300, and I didn't realize we owed $300. So I had to try to ask questions in a really small lobby. All that could have been resolved with a little bit of technology. So if that had been communicated with prior to, whether it be email or text, I think that would have spoke volumes. And then that also goes back to the trust too, because that created a level of issue of trust with that provider for my son and my family. So I think, just speaking from my personal experience, I think trust is a huge factor in providing accurate estimates for sure.
Great, thanks, Eric. Kind of a follow up to this question on the on pricing estimates. Just, can you tell me a little bit about your experiences with the No Surprises Act? Is that still a challenge, kind of meeting the requirements of that specific legislation? Are there state legislation that you each have to worry about? Anyone want to take that?
Yeah, I'll hit on that a little bit. I think what's unfortunate is the intent of what the legislation was meant to happen really is not what is happening. All it's done is add additional healthcare costs because of the amount of time we're spending to try to stay within this narrow guideline. And at the end of the day, it hasn't resolved the problem of that quote surprise bill, because no matter how good a job seems like you do with the estimate and with the understanding up front, there's always that patient that, you know, they're going to get their bill after Blue Cross finally gets around to processing it 6 months later. And, you know, oh, I'm surprised. It's a shock. And I think trying to combat that is getting increasingly difficult as more people hear what the public and or media version of No Surprises Act really is.
Mm. Thanks, Mike.
Yeah, I'll say the No Surprises Act. The No Surprises Act is, from a self-pay perspective, I think we do a great job, to what Andy said, right? We put a lot of time and effort into it. But I got to tell you, you only know so much at the time of scheduling. Right? I think anybody that's in healthcare knows this and can agree to that. Right? I used to have oversight of scheduling with a different health system. No matter how many times you ask, what are you coming in for? Patients don't want to share all of that information with a scheduler. I don't blame them. Right? I understand it. But if you're telling us that you're going to come in for A and then you also talk about B or need additional labs, we don't know that. No health system can know that. And that impacts those out-of-pocket costs.
Yeah, I mean, I'll jump in as well. I think we heard that little example of, hey, when you take your car to the shop, you know, here's what happens, and we all realize healthcare will never be that. There's just way too much variability in what can happen to your care. Oncology, it's exponential. What can happen to your care when you actually start treatment, as opposed to when you, when you're mid-treatment, when you started it. And Ryan, I agree with you. You know, not only do patients not always really want to disclose all that, sometimes in oncology, we don't even know. Right? So we start down the pathway, you have a suspicious something, and then we're off to the races once it's sort of defined and we go forward. So that's part. And I think a lot of us are sort of waiting and see on the well-intentioned patient price transparency to see what happens. But I think maybe the people that were writing the law didn't really understand necessarily healthcare all that well. At least it didn't seem like it. So I think that's part of it. Also, remember, in patient price transparency as a law, there is a huge payer component that they're also supposed to comply with. And we haven't heard much about that recently either. So that's still out there.
Great. Thank you.
I will say, if I have one other thing to just jump in here, is that, you know, we really do focus on trying to provide patients with that best out-of-pocket cost ahead of time, right? And again, consistently, additional things are added to what Andy said, right? And you need to provide those additional services. Something that we've talked about is really having our physicians and educating them and telling the patients, you know, if we want to do this today, that's fine, but you're going to have to come back in. But at the same time, I don't think UW Health is the only system with access issues. So if patients actually took us up on this and said, I'm not going to have that addressed today, we're going to go down and have it done another day, they might not get in for another 6 months. I'm not saying that's bad. I'm not saying that's good. I think that's just the reality of healthcare in the United States right now.
Yeah, thanks, Ryan. Move on to the next question here. And you have all touched on this a little bit too, but how are you interacting with patients pre-service to help them understand cost-sharing components like deductibles, copays, and coinsurance? You know, each of you has talked about the importance of education and about the importance of pre-service collections or point-of-service collections. So yeah, can you dive a little deeper into the sort of like strategies that you're using to educate patients about these sorts of cost sharing mechanisms? And yeah, Andy, would you like to start?
I think we all were on this page pretty consistently. Pre-service is what we're all trying to get to here. I think the the old model of the surprise bill at the end, here's how much you owe, isn't working for many anymore. So I think really what we have tried to do at Moffitt is really focus. We use what we call our financial clearance unit, which is basically at the point of scheduling, to really help patients understand as best we can, I think we've all agreed, what their out-of-pocket with is and what their options are. So as many as possible, that is discussed upfront prior to treatment. Now, there are, of course, variations that go there, but that is the place where I think those discussions happen the best before patients start their treatment.
Thanks, Andy. Mike, do you have anything to add?
No, I mean, exact same scenario. You know, I know that we've had some discussion about, you know, trying to do more community outreach type, you know, educational stuff that's not in the patient setting. But it's hard to do and hard to get that interaction.
Thanks, Mike. And Ryan, what about you at UW Health? How are you kind of educating patients about these cost sharing mechanisms?
What I'll say is inconsistently, right? As much as I would prefer not to, our goal is to get an estimate out to every patient for every service, right? That we're far from that, right? For a number of different reasons, right? But we're still getting those out. We're getting them out to the patients in their preferred communication preference, right? Again, via a push from the portal to the app on their phone, an email, a text message, whatever. Two, I think, fairly unique things that we do is anybody that has an estimate of $500 or greater, we actually call that patient, right? We've measured the effectiveness of that. Nobody answers. We all know that you do an outbound call. Very, very few people are answering, right? But it prompts them to take action. So we've measured the payments that we get by different balance band, right? We see an increase, a significant increase for those that have a $500 balance or higher compared to those that had a $300 to $500 balance. And it's that extra prompt and that extra push, right? I would love to lower that balance. I don't have the staff to lower that balance. We're looking at automation in the space, right? Like we need to do better in that space. But I think that's pretty unique that we do that. And then the other thing I would say that we do is at check-in, we talk about pre-service, or we talk about payment expectations every time, right? Even if you have a $0 balance, there are times when we send you an estimate for $0 if you're coming in for an annual physical. And that's a whole other thing because no adult actually goes in only for a physical, but that's a different problem, right? So we talk about that payment expectation, right? If you use kiosks with us and you don't pay your estimate, you don't get to complete the check-in workflow at the kiosk. You're directed to a desk to have that conversation.
Wow.
Right? We really are transparent and have those conversations. We're supposed to have those conversations upon every arrival, right? So just, again, I think it's just messaging and trying to be as transparent as possible.
You know, Ryan, I have a quick question for you. You know, I've spoken with some other folks about this, and was it hard kind of getting staff? It sounds like you guys are big on this at UW Health. Has it been hard to kind of like retrain staff to have that conversation up front? I've heard that can be difficult.
Oh gosh, yeah. Like there's no question about that. And I will say that also because of our reporting structure, not everybody that's checking in patients reports up through centralized registration. You know, we still have a number of folks that report up through the ambulatory side, and there's high turnover in that space, right? There are different expectations about what is or is not in your scope of your work, but we push that. We send out prepayment collection data for every front end user to every one of their managers on a monthly basis, and we take it to our VP meetings, right? This is a huge push for us. And the expectation is that we continue to train and we continue to be very transparent, not only to the patient, but to the front end users and their leaders about who's actually collecting.
Great, thank you. Eric, do you have anything to add?
Yeah, I'll kind of piggyback off of one of the things that Andy mentioned earlier about the price transparency regulations. I think one of the key things, again, go back to the theme of education, but with the original price transparency requirements to put, all the charges on the website, right? If a patient had kind of that shopping mentality where they're shopping for services, viewing charges is going to be kind of unclear to a patient, because what a charge is different than what's a contractual amount, or what in-network versus out-of-network is. So all that factors in. So things like an estimate being able to be sent to the patient, one-page breakdown of what their out-of-pocket is, if their plan is in-network or out-of-network, all those things do, right, factor into it. So that also translates to the surprise bill too. So if a patient has a procedure, or maybe think about labor and delivery, if a family has a child and there's a physician that's out of network but one is, those all factor into it. So just explaining that up front as much as possible with disclaimers is also very important.
Great, thanks, Eric. Moving on. So you've all talked about the importance of collecting pre-service or point of service, but how are you interacting with patients post-service to collect money that's still owed? And Mike, would you like to start?
Yeah, I think it kind of goes back to the conversation about technology. That's our biggest partner with trying to do post-service collections, because I think everybody's got the same problem. You can't possibly hire enough people or afford to hire enough people to really do this, and to do it consistently. We're using secondary collection vendors. We've got dialers, those reminders. Sometimes it just takes a prompt. And I think the biggest impact, as we've already seen, is fully rolling out the MyChart system, where the patients are getting the notification, but they're also seeing it when they're going in to check their notes from their last visit or to make another appointment. It's in front of them continuously that way. Even if they're, it's easy to sometimes just drop that bill that comes in the mail in the trash or ignore it with the rest of the pile. But when you're getting that prompt continuously, I think that's going to be the key going forwards. And really, it's technology. That's going to be the solution.
Thanks, Mike. Andy, do you have anything to add?
Yeah, I think what Mike said is a good point. Like, get it in front of them. I think options is something else that helps a lot with this. If you have a good toolbox to tell patients, hey, look, there are options, not just maybe but ways to pay, right? Do the text to pay, do the scan barcodes, right? So that you kind of getting out there with patients a lot of pay. And also let patients know there's a payment plan option for them. Let them know they can opt into that. Let them know how to opt into that. Make it pretty easy for them to do that if they need to. I think all of those things are good things to have in your toolbox. I think we all try to settle it up front as best you can so that you don't have to collect so much on the back end. But we will always be collecting back there. So I think giving your patients the knowledge of what's available for them up front and then again in the back helps them understand you have options. That's helpful.
Great. Thanks, Andy. And Ryan, anything new you're doing at UW Health post-service?
So I'd say very similar things, right? We're pushing the different communications that are going out via the push notifications to the app or the email. We do it at the time whenever a balance goes to self-pay. We have a new balance notification that goes out to those patients with the total amount that just dropped. Again, it's to prevent statements, right? The creation of the statements, sending of the statements, different things like that. That's all automated. We do it whenever there's an updated patient balance as well. And when a balance is overdue, all those notifications are automated. Depending upon the patient balance, we also use a propensity to pay score or the patient's payment history with us. And we place outbound calls to patients on days 45, 65, or 90 after the balance was placed. And then before sending it to collection agencies, we send the final letter and do all of those different notifications. And then lastly, we ask at every outstanding balance, or I'll be asked for outstanding balance at every arrival. Something I think fairly unique that we've started doing is started looking at where our back end collections are coming from by department. We want to see what we can do to move those payments up front. I don't need to see the patients that aren't paying. We have processes in place for patients that aren't paying, what I just talked about. What we could do a better job of is identifying those patients that are willing to pay, and how do we better communicate them further upstream to get them to pay pre-service, right? And we're finding things, right? Weird things, like we have package pricing, right? That you say, hey, you're coming in and you're getting X, Y, and Z. We're taking the payment, but we're not posting it until after the date of service. Well, now our pre-service collections look like we're doing something, or it's negatively impacting our pre-service collection. I understand that's just a reporting thing, right? But those are areas where we're like, okay, what could we do better to help patients understand those out-of-pocket costs?
Great, thanks, Ryan. Eric, what are you seeing across the industry? What are you seeing that's working and what's not working?
Yeah, I mean, I'll echo several things that were said already around the time it takes to get a bill. The quicker it is, the better. You know, that again, going back to technology, right? So the patient can get a text or an email quicker than a mailed statement, right? And I think it also factors into having technology to be able to really get the bill out, whether it be the claim itself processed quicker. And then I've seen scenarios where maybe a provider sends a bill. This is my personal experience again as a patient, sends a bill 6-7 months later, and that's sometimes difficult to deal with, right? So that speed is key right there. I think the other thing is that personalization is critical too. So if a patient gets a bill that's $800 and they get a link just to say, hey, log in and pay your bill without an explanation of the bill, I think that's also important. So and that personalization component too, and the payment plans, making it more affordable, all that's really important.
Thanks, Eric. Ryan, it looked like you had a point of agreement there.
I think it's just the personalization really needs to be taken into account, right? And making it as easy as possible, but helping the patients understand that personalization, right? Having on an actual statement to a patient, this balance is from, here's the deductible, here's the co-insurance, here's the copay, whatever it might be, right? We don't have that right now. In our current statement version, it is just, here's your balance with no explanation as to the why. And I can't stand it. We're working on improving it, right? But as the patient, when I get a statement for any of my 3 kids or my wife or whatever, right? And it just says, I owe $500 and I have no explanation as to why I owe that $500. I have questions and I have to call my team to have this conversation. If I can't understand that statement, and I'm not putting myself on this hill or anything, but this is what I do day in and day out, right? If I can't understand the statement, I have no expectation for a majority of our patients to do so. So to Eric's point, personalizing that, being specific to the benefits of that patient and helping them understand those costs is imperative. And that's something that we're striving to meet.
Thanks, Brian. I appreciate that. No, I think that is huge. That sort of personalization. I think, all of us can speak to net of experiences as patients. We not only work in this space, but we also, are patients in this space too. So, yes, it's affected all of us. Moving on. Are you working with payers at all to improve the payment experience for patients? And Mike, do you want to get started?
Well, how to say that nicely? Yeah, I mean, it'd be great, but I'm not sure that any payer really cared, to be totally honest. It's something that I've talked to some people about lately. How different would the entire process be if the payers paid the total amount and the payers collected their co-insurance and portions from the patients directly instead of from the hospitals? It really should be that way, because the payer has a contract with us. They've got a contract with the patient as their customer. It would change the entire industry. But yeah, unfortunately, we're just trying to get some payers to quit sending medical record requests on every single patient. So one step at a time, right?
Thanks, Mike. Andy, would you like to add to that?
Well, I mean, I think I agree. I'm not 100% sure how much the payers are all that interested in doing that, particularly sort of like not their problem. But I think two things we have tried to track, and I don't want to say we're working cooperatively with them, but we certainly have started to create what we call payer scorecards on our end to give payers feedback from a contractual point of view to our managed care departments to say, look, the patient mix that you're giving us has a lot of very high out-of-pocket costs. So in other words, in our market, you're selling a lot of really high deductible plans. We need to compensate for that. And so we sort of bake in our bad debt numbers also in relation to that, of what becomes uncollectible, and present that to payers and say, yeah, look, this is uncollectible to us. So you're going to have to do something with us from a contractual point of view. That seems to be the only way we've ever got their attention on how well their patients are paying, is when we start asking for concessions. But then again, I don't know what payers can do really to drive their patients getting to pay their claims, really. I mean, I think, I love the idea, like, hey, just pay us what you owe us, payer, and then bill the patient for the rest. It's not our problem. That's kind of not how we were set up, but I think it's a great idea, and we should go forward with that.
Thanks, Andy. Ryan, how do you feel about that? I assume you agree.
I mean, I've talked to Mike. I remember sitting in San Antonio and talking to Mike about this not super long ago. But I would say from the payer side of things, we have a health plan that's owned by the health system. And even just educating those individuals that I talk to on a monthly basis, who are the leaders in that space, about our payment expectations has been eye-opening to them, right? It's not in their role to think of it from that perspective, right? And I think that this is just giving them a different perspective to take into consideration. As you're selling these high deductible health plans, just know we're billing your patient. What education are you doing to help them understand the resources available, right, to them, and what's happening when you're signing up for some of these plans with these huge out-of-pockets? It's not like all of a sudden your premium's just dropping, you don't have additional costs. As soon as you go in, there's additional cost. It's your responsibility as the insurer that's selling this to help them understand that and to educate them, right? It shouldn't be my responsibility in that space, but I feel like it is my responsibility to help educate the payer, right? Another thing that we're really doing is really having a better and better understanding of RTE, that real-time eligibility that we have with our payers, right? And I talked about this before, but every payer is providing us with different information in a different field. There's no standardization. So we're using hours and hundreds, thousands of hours of FTE, getting down to the plan level to try to understand if they have a telehealth benefit. Right? We just looked at an example where we looked at 10 different plans, or payers, not even the plans, payers, and they all reference telehealth in a different language in a narrative. And they all put that information in a different field, right? It's helping them understand that there has to be some standardization, because otherwise we can't provide an accurate estimate to your patient, and we're providing them with a poor patient experience. And we're going to have to refer them back to you to say, well, your payer is not giving us the information that we need. We're trying, right? So I think that there's some reality to how we're getting the information that the payers need to understand. And I'm not saying I understand everything on the payer side. I don't, right? But I think that open communication back and forth is really important.
Thanks, Ryan. I'd kind of assume that some of this public pressure that payers must be feeling would encourage them to cooperate a little bit more. Eric, is that just not the case? Is that not what you're seeing?
Yeah, I mean, I would say what we hear in the news versus what the reality is sometimes aren't the same. But yes, I would think the public pressure is there for sure. I mean, going back to what Mike said, I think that suggestion is interesting, because that would be kind of eliminating some finger pointing, because, as a patient, if you're calling your insurance company and the insurance say, well, the provider didn't provide us documentation. When you call the provider says, we provided all the documentation we needed. And then just this finger pointing back and forth. So from the patient's perspective, again, I'm going to key on that patient experience for a second. That goes back to the education, that goes back to the trust. Who does that patient trust? Who's telling the right information? Right. So again, the real-time data, again, back to what Ryan was saying, having the real-time data is important. Again, letting the patient know what to expect through the billing process, all that I think is a huge factor here. And again, the patient doesn't really care what the problem is as far as, is it the insurance or is it the provider? They just want to be able to be taken care of and understand their bill. So I think that's really where, again, back to technology, that's where it comes in.
Great, thanks, Eric. Before we move on to our final question, I do want to remind our audience that you can submit questions for a brief Q&A at the end of the session. And we'll move on to the final question here, and that is, how do you adjust strategy toward the patient payment experience when the economy is either in decline or perceived to be in decline? I think at this current moment in time, there is a lot of uncertainty around economic conditions. And Eric, we'll start with you. What are you seeing across the industry?
Yeah, I mean, I think having a tougher economy right now is, in general, whether it be inflation or political climate, you name it, there's several things out there right now. We all know it. I think from a patient experience, again, empathy and flexibility, we've talked about it several times throughout this discussion, but the personalization, payment plans need to be easier to access. Again, explaining to the patient what they owe, even extending out payment plans, because any provider has their own business rules. Like some might not even take payment plans. Some might say we're going to stop at 3 months, but in a tougher economy, maybe going out to 6 or 9 or 12 months for payment plans without even needing, traditional financing. Those are all things that a patient can see as, hey, that's flexible, right? More affordable. I think messaging itself needs to acknowledge reality. I don't think patients respond well to hard line reminders when they're dealing with something like job loss or inflation. It's hard to see that on a personal level, right? Some might be dealing with job loss, but others might not. So again, having those flexible payment options is something critical. And then it was mentioned earlier about financial assistance too. So having technology to be able to indicate that as well can help alleviate patients' concerns about the affordability of having the care they need. So that's all important.
Thanks, Eric. And that kind of reminds me, Andy, you spoke a little bit earlier about something you do with your patients at Moffitt Cancer Center, and that's up front, you do kind of look for those assistance programs. Is that something that works during these times?
Yeah, I think it sure does, and I think it. If you move all that forward, like we've sort of been talking about, patients can begin their treatment with an understanding. I think the other thing too is have flexible processes that actually review. So a lot of times this stuff happens mid-treatment or something. So just make sure patients can reach out and say, I've had a change. Like I've just lost my job. What options for me? And be compassionate, like Eric said, to that, and not be like, well, sorry, but you got to pay it, right? So that is when flexible payment terms come into play. If you've got that, or even maybe evaluating that person for financial assistance mid-play if you need to. So if you have a process that's built into that, say, hang on, let me go ahead and see now that your situation has changed, maybe you qualify for financial assistance where you did not earlier. So let's go ahead and take a look at that and see if that worked for you or some version thereof. Long-term, being able to add term to payment plans also helps. We actually use a vendor for our payment plans, and they do have the authority to extend that term if a patient experiences some sort of an issue. The other good thing that they do is they also have a good process, and we do as well, to check back with patients and say, hey, there was a downturn, you had an issue. Do you still need to pay this over a really long period of time, or do you want to go ahead and get rid of it? And can we incentivize you in some way to do that? So I think it is a very dynamic environment, and you kind of have to build a dynamic system to go with it.
Thanks, Andy. Mike, do you have anything to add?
Just, flexibility is the key word. I think we've got to be able to react to how things are changing. I mean, it seems like the economy thought process changes weekly here lately. It's oh, it's great, oh, it's bad, and I think you get, even if it's kind of a positive tone, you still get some concern when it comes into payment plans on one of these large deductibles where the patients want to know that they do have some flexibility and that they are you are hearing their concerns.
Thanks, Mike. And Ryan, you want to close this out?
Yeah, I don't think we've had a lot of shifts in our strategy with the way the economy is moving, because our entire strategy has been to be as transparent as possible with the patient's out-of-pocket costs and what resources we have available, right? 501R says that you have to provide financial assistance information, right, for every admission. We do it at every encounter. If it's a virtual encounter, if it's an outpatient encounter, our system prompts to provide information or ask the patient if they would like information about our financial assistance program every time, right? And that's something that we are sticking to and we're adamant about, while at the same time we're asking for additional out-of-pocket costs, right? So we really want to make sure that information is available to all patients at all times. The other thing I'll say is, there were a few references about payment plans and being more flexible with payment plans. We've actually taken a bit of a different approach and just recently increased the minimum amount on our payment plans and shortened the amount of time that our payment plans are being provided, right? They were very generous. They had a $25 minimum payment a month. That's just not sustainable. If you can't go above $25, we need to be doing a better job of talking to you about financial assistance, right? So that's on us. I'm not saying ours aren't super stringent, right? They're more stringent than they have been. And I think that's okay. That AR was just sitting in the books for years and years and years because we just had such generous plans that we need to be realistic with that patient. And if they can't afford, $30 a month, well, let's have a more generous conversation about financial assistance.
Great. Thanks, Ryan. Thank you all again. Great answers. Really interesting discussion. We are now in the Q&A portion of the program. We do only have a few minutes left. We do have one question for Ryan with UW Health. And that question is, what sort of patient feedback have you got regarding patients and the different discounts on their bills?
Not quite sure what we mean by the different discounts on our bills. We post our contractual discounts on there, our self-pay discounts if a patient is truly self-pay and is uninsured, as well as our financial assistance discounts. Again, I think it's coming back to just using plain language on the statements and helping patients truly understand what we're saying in our statements ourselves. And maybe I'm missing something if anybody else has anything to contribute there.
I did hear Andy speak about, sort of some of the work that they were doing with patients, regarding the different discounts that you could find through various programs. Maybe you have something to add to that. What kind of feedback did you get from your patients there?
Yeah, it wasn't so much around discounting differently. What we do is we have some programs that are patient assistance related. So in other words, we do free drug programs. We do patient copay assistance programs. Most of those are built around the oncology service because they're drug related, but a lot of the pharmaceuticals have programs that you can opt in. And we do that on behalf of patients to try to lower the cost for their oncology drugs. And so I'm not sure if that's what the question was about, but yes, we do that.
Thank you both. That is all the time we have for today. In closing, please note that our next Winning Edge program on June 3rd will cover the Winning Edge for reducing contract labor. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on patient payment success on our website, healthleadersmedia.com. I want to thank our panelists, Ryan, Andy, Eric, Mike. I thank you all for an excellent discussion. And thanks to our sponsor, Waystar, for making this program possible. And finally, thank you to you and our audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next Winning Edge program on reducing contract labor. Thank you.